Greetings, everyone. We would like to welcome you to our live webinar presentation, Strategies for Reducing Population Costs, Data Mining Tactics for ACOs Facing Greater Downside Risk. If you were on an airplane right now, you need to listen to some safety instructions before the plane takes off. So buckle up and please pay attention to these brief items of note before our webinar takes off today. During the webinar, all attendee lines will be muted. To ask speakers a question, on the left-hand corner of your screen, you'll see a blue Ask a Question box. Simply type in your question and press Send. Your login instructions included a downloadable link to the PDF version of the slides for today's presentation. Remember that audio requires use of your desktop or device speakers or headphones. If you haven't done so already and would like to purchase a copy of the video recording of the session or need any assistance during the webinar, please contact our Healthcare Web Summit office at 209-577-4888. Under the final rule for the 2019 MSSP Pathways to Success, ACOs have a shortened time frame before they must move to downside risk. Under the new rule, there will be a more urgent need for ACOs to reduce population costs. Two major tactics are typically implemented by health plans and ACOs to reduce population costs: demand management and supply management. This Milliman presentation focuses on supply management and, in particular, data mining tactics that identify medically unnecessary services. Our speaker today is Kate Fitch, Principal and Healthcare Management Consultant in the New York office of Milliman. Kate consults to provider groups, evaluating and engaging in population risk contracts, ACOs, MSSPs, IDNs, etc., including assistance in contract evaluation and financial feasibility modeling based on benchmarking population claim cost and utilization experience. Kate oversees the development of the Bundled Payment Interface tool that serves 200 plus hospitals and the ACO Insight tool that serves 50 plus ACOs. So, without further ado, our speaker is now ready to begin.
Good day. It is a pleasure to share with you many of the insights that I've gained over the past several years working with population health claims. So today I am going to talk about data mining tactics for ACOs who are now facing greater downside risk. First, we'll just briefly touch on why the faster movement by payers to downside risk. Why are we here? And then the meat of this presentation will be sharing with you effective claims data mining tactics that provide a roadmap for cost reduction strategies. And then we'll end with discussion. So we'll get started and asking the first question, why this faster movement to downside risk? And particularly this has been coming more and more highlighted because of the final MSSP rule, Pathways to Success, which does require faster movement to downside risk. Under the previous MSSP regulation, ACOs could stay in an upside-only track for up to 6 years. Those were 2 3-year agreement periods. Under the new rule, which starts July 1st, ACOs in the basic track are required to assume downside risk in year 3 or 4. 4 if the ACO is a low-revenue ACO, new to MSSP, and inexperienced with risk. Those who are already experienced with risk will be starting in the enhanced track. So again, just more focus on this faster movement. And why is CMS in particular pushing this faster movement to downside risk? It's also being pushed on the commercial side, Medicare Advantage side, with risk contracts, but for CMS, these are some quotes in their Pathways to Success proposed rule, which came out last December. The shared savings program, according to them, has shown increases in net spending for CMS and taxpayers, in part because the majority of the ACOs, 82% of them, were in upside only. We're not taking downside risk. Second quote from them, data on ACO performance to date has shown that ACOs that are not at risk for cost increases end up increasing Medicare spending in aggregate. Again, right from CMS. And the opportunity for bonus payments if spending is low without any risk of losses if spending goes up, along with providing waivers, may be encouraging market consolidation. That is a fear of CMS, and consolidation reducing choices for patients and can ultimately increase costs. So again, a lot of concern by CMS to push MSSPs into downside risk sooner. The CMS Administrator, Seema Verma, stated after 6 years of experience, the time has come to put real accountability in accountable care organizations. Medicare cannot afford to support programs with weak incentives that do not deliver value. So this is where we are, and this is where the commercial market is moving as well. Again, there's really no turning back. What I want to talk about is some of the tactics that ACOs, successful ACOs, and health plans use with managing population costs. Two major tactics are typically implemented by health plans and ACOs to reduce population costs: demand management and supply management. By demand management, what I'm referring to is improving the health of the population, which therefore lowers demand for services. If you have healthier people, there's lower utilization of services. And those type of initiatives, such as disease management, case management, wellness programs, preventive care, having disease registries, closing gaps in care, enhancing adherence, medication adherence, et cetera, are those demand management, but they're often characterized as soft savings. Not hard dollar savings necessarily. Sometimes these programs work, other times they don't. Many ACOs focus on these type of tactics, and that's what they've been focusing on. The harder type of tactic is supply management. That is reducing utilization of medically unnecessary services and also reducing the cost of medically necessary services, such as shifting to lower sites of service. Those types of initiatives include utilization management, such as pre-certification, inpatient utilization review, emergency department diversion programs, specialty referral management programs where PCPs are expected to practice at the top of their license and not refer always to specialists for every condition, clinical decision support programs, site of service shifting from higher cost to lower cost. Again, these generate hard dollar savings when you reduce utilization. And that is what I'm going to focus on today, identifying those opportunities for reducing medically unnecessary services, as well as shifting to lower cost site of services. We've seen a lot of literature out there in support of the fact that there's significant opportunity to reduce medically unnecessary utilization. The Dartmouth Atlas does publish frequently on the significant variation in Medicare fee-for-service utilization for surgical procedures, end-of-life costs, chronic illness care, et cetera. The Institute of Medicine reports that 1/3 of healthcare spending is unnecessary. That also includes administrative costs and fraud and abuse, et cetera. Milliman has what we call our Milliman Health Cost Guideline benchmarks, well and loosely managed, some of you may have heard of, and we identify approximately 1/3 lower costs for Medicare and commercial populations that what we call are efficiently managed or performing at the 10th percentile best performing. And again, based on empirical data, claims data. So again, that variation in cost and utilization is very well established, and that's why people are going after reducing medically unnecessary services. The elephant in the room, though, is for health system ACOs, there's really a need to balance the impact that reducing utilization will have or shifting site of service will have on a hospital system's revenue. So if you are going to shift from a hospital outpatient setting to a physician office for chemotherapy, that is going to reduce hospital revenue, or reducing admissions is going to reduce hospital revenue. So there's always a balancing act. And I think that's been, for ACOs who do not have downside risk, that has been the part of the equation that has not been as stressed, because it's easier to do more of the supply, the demand management side. So I'm going to get into data mining. This is what really excites me. I'm very passionate about data mining. I have about 60 ACOs data on our platform. We mine this data day in and day out, and it's I have a team of people that do this, and we've learned a lot of lessons from our analyses. And I have 6 steps here that I'm going to go through on data mining. The first is, and again, any deal that a health system has with a commercial payer, Medicare Advantage payer, or MSSP, Medicare fee-for-service, you really have to insist on getting claims data. Claims data is really your map to how to identify opportunities to reduce costs. And I know many people have trouble getting claims data from some payers who don't want to expose reimbursement rates for different providers in the region. And Medicare, luckily, with the MSSP program, has been providing those CCLF files since the inception of the program, and they're very rich data sources. So taking whatever data feed for the population at risk and grouping the claims into meaningful categories is really step number 1. It does require some administrative claims data expertise and some sort of grouping logic. So taking every claim for a given year, for a particular population, and grouping that into meaningful categories that I'm going to speak about shortly, but that's really step 1. Step 2 is to then understand what's driving cost, grouping those into meaningful cost categories, and building what I call an actuarial cost model, which I'll show you shortly. Third step, though, once you build a cost model, to identify where the opportunity is, many times requires comparing one's performance to benchmarks. Then when you identify where there's opportunity, particular considerations: which services provide the greatest financial opportunity? How much effort will it take to impact a particular service? There could be a very heavy lift and political capital that one needs that just is not worth taking on. So again, evaluating that question as well. How feasible is it to reduce the service? And how will reducing the service impact the ACO health system's revenue? Again, that is a very important question to ask. Can you make up for the reduced revenue, the reduced utilization, with the shared savings or with shifting leakage, et cetera? Step 5, profiling providers to target for these opportunities. You may have opportunity, but who are the providers that are driving that opportunity? Can we profile those providers and really provide them with data to create data-driven decision-making? Last, step 6 is to identify leakage opportunities. So I'm going to go through all of those. But first, what I call a treasure map, if you will, is one's actuarial cost model. This is a sample of a Medicare population in the middle columns and a commercial population on those 2 right columns, data for a given year for 10,000 Medicare members, 30,000 commercial members. We've taken every single claim that was incurred and paid during that particular year and grouped them into about 30 categories here. And you'll see in the green lines are 3 major service categories: inpatient services, outpatient services, and other services. So those are the green lines. And these cost models are what health plans live and breathe by. They have their premium rates, their MLR, medical loss ratio is really these claims. That is the amount spent out of the premium dollars. So for Medicare, if we see in the very middle top column, the annual per member per year paid about $10,000, $9,759 per member per year is what a typical Medicare beneficiary or average Medicare beneficiary spends as well, whereas the commercial, $4,320, that's allowed, that includes the cost sharing. The Medicare numbers here are paid, that's net of cost sharing. That's what's paid by Medicare to the providers. So we have then where is the service that could potentially be reduced, what's driving that per member per year cost. And so we have a percent of the paid or allowed amounts. You can see the yellow highlighted lines are the services that have high opportunity, really drive a lot of cost. Again, these particular lines, every claim was allocated to one of these lines based on ICD-10 procedure codes, revenue codes, CPT codes, HCPCS codes, place of service codes, specialty codes, etc. So every claim gets grouped, and you see here 41% of total Medicare spend is inpatient stays. 21.6% of total commercial spend inpatient stays. So that's the biggest chunk. Sniffs, skilled nursing facility here is 9%. You can see highlighted in yellow for Medicare. It's very small for commercial. You have ER observation, 7.5% for commercial, so it's a big cost driver. If you can reduce 20% of that, you've got big 1.4% of total spend reduced. So again, you can do the math on this, hitting lines by a certain percent reduction that you think you can get, and we'll talk about how you would go about feasibly estimating how much you could reduce these lines by. Facility outpatient surgery, highlighted in yellow, about 6 lines down, is a big cost contributor. 9% of Medicare spend, 15% of commercial spend in a commercially insured population is based just facility-based outpatient surgery. That's the professional and the facility reimbursement. And then we go down with high-tech imaging. Infused injectable drugs is another big cost driver, 8% of Medicare spend, 6% of commercial spend. One might ask, but what can I do about those injectable drugs? Is there really opportunity? What we'll see further along is how to drill into these lines, because that's really where the gold is, where you can identify if there's opportunity. Hospice and home health is a bigger opportunity, the last of the yellow highlighted lines in the Medicare model there. So again, this is really step 1, but step 2, benchmarking. Even if I do have a lot of spend in inpatient admissions, well, maybe that's fine. Maybe I'm doing well. How do I know? Benchmarking one's performance against some sort of benchmark is really critical, but it needs to be on a risk-adjusted basis. You can't compare utilization for hospital inpatient admissions if you haven't adjusted for the underlying demographics and comorbidities of the population. So it's very important to risk adjust when you compare to benchmarks. Also may need, if you're looking at cost, benchmarking costs, really fee schedule adjustments need to be made because some reimbursement may be much higher in some regions than others. A small sample size needs some credibility adjustment performed. Regional adjustment may be necessary, and benefit design adjustments. If it's a high deductible health plan versus a PPO, there's different utilization that you'll notice and needs to be adjusted for. So one might ask, where should I start? Where's the gold? we saw 40% of the Medicare cost was inpatient. So starting with inpatient, what I'm showing here is medical and surgical inpatient admission utilization rates per 1,000 members per year. Again, health plans live and breathe by their utilization per 1,000 for particular services, and ACOs should as well. They should know these numbers, have these numbers down. What I presented here, you can see for the Medicare, 341 annual admissions per 1,000 Medicare beneficiaries is what this particular ACO was performing at. We compare that in the last two columns to what we call, in Milliman terms, loosely and well-managed admission rates. Loosely managed is national average. Well-managed is 10th percentile best performing. And these benchmarks have been adjusted for the underlying demographics of the ACO population. So they represent what a population that has the same demographics and chronic comorbidities would utilize in a given year. So you can see this particular ACO is quite a bit higher, 341 versus 200 for well-managed. Again, that's happening in some parts of the country. It's not a made-up number. Commercial, you can see, of course, much lower utilization, and I have not included maternity, which would bump that up another 10 admissions. But again, this particular ACO performing or utilizing more admissions per 1,000 than or even the national average. So, okay, that's interesting. But what do I do about it? Are there particular admissions that I can drill down into? So first we had the total admissions high, then we got into medical surgical, then are there particular types of admissions? So here I'm showing for Medicare on top and commercial on bottom, the top 8 DRG families. We've combined all of the heart failure admissions, the 3 heart failure admissions, the 2 lower extremity admissions, et cetera, and provide, again, these are benchmarks, loosely and well managed, compared to this ACO's utilization per 1,000. So we can see heart failure for Medicare, always the highest, or a lower extremity arthroplasty, joint replacement is typically up there, along with sepsis. So those are your 3 highest. And for commercial, we have a different mix, mental disorders, joint replacements, et cetera. But being able to understand what types of admissions are driving my higher utilization is very useful, although, again, does an organization want to reduce their surgical admissions? That is a big moneymaker, and so that admissions are those that are potentially preventable. And the potentially preventable admissions we often refer to as ambulatory care sensitive admissions on the medical side and preference sensitive admissions for surgical procedures. The ambulatory care sensitive admissions are AHRQ. They have logic. They publish annually. They update the SAS logic that we use and run on the claims data to identify, again, this is a subset of the admissions. Here, 23% of the Medicare admissions are what we call ambulatory care sensitive. Admissions that, if there was more aggressive care in the community, the exacerbation potentially could have been avoided and they wouldn't have needed inpatient care. If the heart failure had been more aggressively managed, they wouldn't have had the exacerbation that would require inpatient IV diuretics, et cetera. So these are very well known, the ambulatory care sensitive admissions, both for Medicare and commercial. You can see commercial, it's only 7.2% of total admissions. Medicare, it's a much bigger number, whereas potentially or preference sensitive surgical procedures, which are surgical procedures that could be medically managed, a portion of them could be medically managed. Most need surgery, but there's a percentage, and that's what we show on the bottom here. And for commercial, that's a much bigger percent of total admissions. 14.3% of total admissions are what we call preference sensitive. We also see preference sensitive surgical procedures on the outpatient side, and there's definitely opportunity there as well. So again, question is always weighing that with, do I want to reduce revenue? Now, another big cost driver, if we see on the top, the last column, and we went back to the cost model, we'd see 9% of total Medicare spend is for outpatient surgical procedures, and 15% of commercial spend is for outpatient surgical procedures. So again, a big cost driver. Whether someone has the appetite to reduce that is another question. Here, just show a distribution of the procedures of CCS categorization of procedures that drive the Medicare lens and cataract procedures. So, I mean, are we really going to reduce cataract procedures? That's probably not something to go after. Is there anything here? Is there even the last one, excision of skin lesions? We see a lot of more even in the physician office, that driving a lot of cost and potentially some of it unnecessary. So again, another way to drill down into what is driving the cost for this population. Are there particular opportunities? Are there outliers? Another cost driver, which we saw back on the first cost model, was about 7% of commercial spend was ER, and about 4% of Medicare spend was ER. So the question is, are some of those ER visits preventable? And what I'm showing here, the ER visits that I showed in the cost model and those that I'm showing here are treat and release ER visits. These are not ER visits that ended up with an admission. What I'm showing in the third and fourth line here, the commercial and Medicare, the red is preventable ER visits and the green non-preventable ER visits. That is based on the NYU algorithm. NYU developed a ER algorithm using ICD-10s in the primary position of the claim to identify those ER visits that could be PCP treated on an outpatient basis or non-emergent, et cetera. So that's the categorization here. What we see with the commercial in this population, 45% of the ER visits potentially preventable, 43% of the Medicare. So again, that just shows another area that may have opportunity for programs to be put in place. If you want to profile, then what are the hospitals? It's not really so much the hospitals that can really prevent ER visits. If the patient shows up at the door, they have to treat them. It's another way to look at this and profile would be by the primary care physician, the attributed lives for each primary care doc, and how their rate of preventable ER visits would be a signal for, hey, we need more urgent care, more hours in the physician office availability, more aggressive care in the community, et cetera. So just, again, more drill downs to do. Another area of which I'd highlighted, 8% of Medicare spend is on infused injectable drugs, 6% of commercial spend. So that is just for the drugs being administered in an outpatient setting. And the biggest driver of that, as you can see on this list here, is chemotherapy. So then some will ask, well, do I really want to go there? Do I want to get into oncology management? Do I want to have care pathway programs? Are there particular cancers that I could focus on? Should I do a further drill down to segment this chemo by cancer type? Are there certain cancer types that are driving the spend? Are there certain drugs that could be interchanged with a lower cost drug? But then we get back into the question, do we want to reduce revenue? Because as we know, the reimbursement on the Medicare side is AWP plus 6%. And so the higher cost drugs get a higher fee for the physicians that are administering it. So whenever we look at the opportunities, we always have to weigh it with what's the impact on revenue. Ophthalmology, we drill into many times on the Medicare side because that is, a lot of that is for macular degeneration, and there's some very high cost brand drugs, and there's some available low-cost drugs that could be substituted. So again, many drill downs on the autoimmune side. On the commercial side, that's a big driver, 13.4%. Is there opportunity to substitute cheaper drugs? Again, those are questions to ask and drill down further. One of the opportunities in particular for Medicare that I'm very passionate about as well is post-acute care. If any of you have an MSSP, everyone's focusing on SNF stays, reducing SNF length of stay, even avoiding people going to SNF because that is a big cost driver. What I'm showing here, and this is just for the Medicare population because commercial has very little post-acute care. There's really no opportunity on the commercial side. Definitely with Medicare Advantage and Medicare fee-for-service. But you'll see in the last column, 13.7% of total Medicare spend is just for cost in the 30 days after discharge. This does not include the inpatient stay. This is just for 30 days of costs. And the first question I have is, well, what are the admission types that are driving that post-acute care? And here's a distribution of DRG families by the percent contribution they have to that post-acute care, with heart failure being 1.2% of the 13.7%, and so that's a big chunk of it. So then the question is, well, what's happening in that post-acute care period that I might be able to impact? Am I having more readmissions or sending more people to Sniffs? Again, you can look at the top ones, lower extremity arthroplasty or joint replacement, as being another one with opportunity. 1% of spend, of total spend, being in just the 30 days after joint replacement. So again, if you think about getting a 2% savings overall, you can get quite a bit of savings just from focusing on post-acute care. And what I'm showing here on this next slide is what we call our post-acute care benchmarks. These are developed by Milliman using 100% sample, Medicare 100% sample data. And what I'm showing here is two of those DRG families, heart failure, which was the highest opportunity for highest spend for post-acute care, and joint replacement. And what I'm showing is the major drivers, 4 major drivers of post-acute care spend: inpatient readmissions, acute rehab use, skilled nursing facility, and home health. So what we've done is, by DRG, we have created, using this 100% data, benchmarks, national average, and 10th percentile best performing as well. But here you can see for heart failure, the readmission rate is 19.6% compared to 16.4% for best performing. On the lower extremity, they're using more, well, actually they're not using that much more nursing home. That could be an opportunity with many of the DRGs. It is, for this heart failure, higher use of nursing home versus our 10th percentile best performing. So again, and with that, many times home care will go up. You'll see in our 10th percentile best performing, home care is actually higher than in this particular organization's experience, but the nursing home care is lower, and so are the inpatient readmissions. So you need to use a little more home care to avoid admissions and avoid nursing home potentially. So then the question is, even with heart failure, if I have a high readmission rate, can I actually reduce is there much opportunity to reduce those readmissions? What are the readmissions that are occurring? And here's another drill down for heart failure, those heart failure admissions, and the readmissions after those heart failure admissions. What were they for? And I've highlighted in yellow about 45% of the readmissions were for admission types that could be avoided, particularly heart failure on the top, respiratory diseases, cardiovascular diseases, etc. You're not going to prevent a cardiac valve from being performed here or someone having a heart attack, renal failure, spinal procedures, etc. So there's particular readmissions that occur you can't really touch, but there is a lot of opportunity. So again, modeling what that opportunity is and what that's worth in terms of dollars. If you had a heart failure program, an inpatient post-acute care, transition of care program that could really focus on that, and based on the data, you might get some significant savings. So we look at all of these opportunities, all these services that could be impacted, that we could impact. But we know to impact anything, we have to get to the physician level. So profiling physicians is critical. And I'm showing here an example of profiling physicians for one service, high-tech imaging, CT, MRI, and PET scans. And this is about 3% of commercial spend, and maybe 1.5% of Medicare spend is in high-tech imaging outpatient. And what I'm showing here is a comparison by physicians. But as we all know, as the old saying goes, my patients are sicker than his patients or her patients. And if you don't risk adjust my performance, you know, it's just meaningless, which is true. Because this physician one may have a panel of patients that's much older and much sicker. So what we've done here is we've taken, based on their attributed members to each of these physicians, we have taken their utilization per thousand of high-tech imaging and adjusted it in the last column by that population's CMS HCC risk score, hierarchical condition category risk score, which accounts for the demographics and the comorbidities of the underlying population, of each individual in the population. So we've adjusted that, and then the last column really has a much more credible comparison of those physicians' performance. But again, this is something that can be done for many of these services. We do it on inpatient, surgical, etc. It's very important when we're dealing with physicians to be sure that we're risk adjusting, because they'll always come back with the, my patients are sicker. Here, another area for Medicare in particular is profiling Sniffs. As more and more ACOs are choosing Sniffs to direct their patients to, or even for next-gen ACOs who can withhold payment from Sniffs and have them earn it back by their performance, you can profile Sniffs in terms of two important metrics: average length of stay in the middle column and their readmission rate back to the hospital in the last column. Those are the two most important metrics for profiling Sniffs. So but the key, and here I don't have it in this slide, but we've just developed a new risk adjuster to compare Sniff performance using 10 different variables to risk adjust, including the prior DRG, the length of stay of the prior hospitalization, the comorbidities, demographics, whether they were in the ICU, and many other variables, because one Sniff could be getting a much higher comorbid patient population than others. So comparing them on length of stay isn't very credible if you're not doing some sort of risk adjustment. So again, more in provider profiling. The last key to this drilling and data mining is to consider another area, another opportunity for revenue, and that is controlling leakage. If we go back to the cost model, and what we often will do is take every single service line and tag every claim with whether it's an in-network or out-of-network provider. And we can, by service line, identify the percentage of every service, that major service, that is happening in-network and out-of-network. Because there's opportunity to shift more out-of-network spend back in-network and make up for some of the lost revenue if in fact, you do reduce utilization. This is one in particular. This is a leakage report on inpatient elective surgeries. And I highlight this because it's elective. So people actually have an opportunity to convince people to use surgeons in their own network. Why would people be going out of network for elective surgeries? And this is, again, from this Medicare population, we have hip arthroplasties first, or lower extremity arthroplasties. 34.7% are being done out of network. And then the question, or spinal procedures, 30.8% are being done. Why are the valves being done out of network? So the next question is really, okay, well, what hospitals are those out-of-network surgeries being performed at? And there may be a reason. Maybe your hospital network doesn't perform cardiac surgery, so there's a good reason why they go out of network. But for some, there's not. And then who are the attributed physicians to that patient that's allowing their patient to go out of network? Why aren't they directing patients to in-network surgeons? So again, this is just a table that shows the performance by hospital, or I should say the out-of-network distribution of cases, of those 35% of cases that were going out of network for lower extremity arthroplasty, and the physicians for whom their patients were going out of network. So again, more drill down to be able to get at actionable items, something actionable. You can take all this data, but unless you make it actionable, it's meaningless. And getting down to the provider level is really critical, and benchmarking performance. So I'm going to just summarize. Again, number one, taking that rich claims data and really demanding that you get that data from a payer. If you're going to go into a risk deal with any payer, you should get data for the population you're at risk for. Building a cost model is really your treasure map. Benchmarking performance, utilization, and cost is key. But evaluating, again, thoughtfully, what services are going to provide the greatest financial opportunity? How much effort will it take to impact a particular service? How feasible is it to reduce the service? Is it too heavy of a lift? How will reducing the service impact my revenue when I reduce utilization? Profiling providers that you want to target, providing them with information that is credible. Comparing them to their peers has to be on a risk-adjusted basis. Identifying leakage opportunities can really help make up for some lost revenue on utilization reduction. And lastly, modeling the potential impact of feasible reductions or shifts in key services. Taking that cost model, hitting certain lines by a certain % reduction, and calculating what does that mean in terms of total reduction. Can I get to that shared savings level that I have contracted to reduce costs by? What is it that I can reduce to get to that 2%, 3%, 4%, whatever it is that you've agreed to? Prioritizing these opportunities to target and creating your roadmap can really get you a long way to success. And we have some speaker questions, and Clive, I know you are going to ask those.
Sure, and thank you so much. That was an awesome presentation. I loved both looking at the 6 steps to data mining. That was really nice, and I love thinking of this as a treasure map. I'm going to go put on my eye patch and pirate hat, but that was really a great presentation. I did have the ability to cheat and see this presentation before you gave it, and so added my questions on at the end, and I'm going to jump right into one. And so my first question is, what steps and how much weight should organizations that serve wider geographical areas, in other words, they're not just focused in one service area, take to factor in the regional variations for benchmarking?
Great. That's a great question. One of the things that I do caution organizations that are benchmarking their performance and want to compare themselves to the region, which is fine to do. They want to see if they are performing better or worse than their regional competitors. But I always caution you should also, your region might be really lousy or it might be great, that it's very important to compare to national as well and best practice in the U.S., not just to your region, because it is a limited view. So that is my response on that.
Okay. And So, some organizations are going to have, and you touched on this some as you talked, but they're going to have less claims history than others. And granted, if they get past history from a payer, that can make up for that. But other than that, what could organizations that don't have so much history do to still build a credible cost model?
I know that's a great question. With the MSSP program, they require that you have at least 5,000 lives. And most commercial deals, you want about 20,000. So again, there may be less lives in some deals, and that does raise the issue of fluctuation with lower numbers and really having bad experience, having outliers that are going to really swing you in positive or negative ways. So in terms of if you have a smaller population, setting up those outlier, really some sort of outlier protection, some stop loss is critical because of that fluctuation. The other question I think you're asking is if you don't have that much data. I mean, you really need a good solid year of data to be able to start the process, get that historical data, and see how you have been performing. See where the opportunity is out of the gate instead of waiting till after you pull the trigger and then they start giving you data and you're just trying to play catch up to see where the opportunity is. So I do think, again, lower amounts of claims data in terms of not getting full claims, that's a problem. I mean, that to me is a red flag for any organization that's going to be contracting and taking on downside risk. You need to get robust claims data and in advance of the contract starting.
Oh, that's well put. Okay, and then my last question is, and you touched on this some when several slides back when you were talking about provider profiling and how. But I'm wondering if you could elaborate a little on, because every organization faces this. How can an organization best address potential provider responses that say their patients are sicker?
Yeah, it's going to happen every time. Again, the risk adjustment is crucial. So that, and also some credibility adjustment for small population sizes that a particular physician may just have too small of a panel of patients to really be credible. But in terms of that comparison, profiling them to their peers, risk adjusting on a demographic and chronic condition basis is critical. And that's something that is not, off the shelf typically that you can get. It does take some finesse to be able to do that risk adjustment. There's risk adjusters out there, many risk adjusters you can use. For a Medicare population, the HCC is publicly available, that risk adjustment methodology. If you're capable of running that on the claims, that would be, a good solution.
Well, perfect. Well, thanks. Those were my questions, and now we're going to take audience questions.
Hello. I do have a question from the audience. Can everyone hear me? The question is, where do you get all of the benchmark information and how to risk adjust without knowing the underlying population risk scores in the benchmark population? So I'm just going to address that. I know we just spoke a little bit about benchmarking and risk adjustment. For the benchmarks that I've been presenting today, those are Milliman benchmarks that are based on the Medicare side with Medicare 100% data. And again, all Medicare fee-for-service lives, we have their data, and we develop these utilization and cost benchmarks using that data. And on the commercial side, we similarly have about 50 million commercial lives. and are able to develop that. But to risk adjust, so what we do when we get a client's data in, a data feed on a Medicare Advantage population or a commercial population, we take the underlying demographics. So everyone has an age, gender band that they're assigned to. Everyone has a chronic condition score, if you will. And that distribution of that population's demographics and chronic comorbidities are applied to the benchmarks, so that the benchmarks we are comparing the population to are demographically and chronic condition adjusted. So it's an apples to apples comparison. We're not just comparing a population to national performance, because national performance, the underlying population could be much older, younger, sicker, et cetera. So we adjust the benchmarks actually to the underlying population. And that's hopefully answered that question. I don't see another question yet. Let's see. Oh, hold on a moment here. Have you ever worked, I see a second question. Have you ever worked with a peer group, national hospital system, or other similar set of organizations to set benchmarks? That's a great question. Actually, and this is public knowledge, I work with Premier, who has about 50 ACO members, and we actually benchmark their performance to each other. Now Medicare does provide also benchmarks for MSSPs based on the performance of the MSSPs, but we have taken the data from those 50 plus ACOs, MSSPs, and benchmark performance amongst those organizations, again, risk adjusting and demographically adjusting for the underlying population. And I do think that, we do see that the ACOs are performing, particularly those who've been in the program for more than 1 or 2 years, are performing better on a risk-adjusted basis than non-ACO fee-for-service lives. So that it is important to, it's one thing to compare an ACO's performance to the national best practice, but it's also important to compare them to their peers, if you will, other organizations that are in the ACO program. Let's see. To get the benchmarks, would we need to purchase the data? Yeah, so the benchmarks, typically when organizations want their population benchmarked, if you will, if there's medically unnecessary utilization, if they're performing better or worse than best practice, 10th percentile, well managed, we will get that data onboarded, and then we will analyze and, again, group all the data just as I showed you with the cost models, and then compare to our benchmarks, which will be demographic and comorbidity adjusted. So, and they're not, again, the benchmarks are only meaningful if they've been risk adjusted for your population. So that is an exercise and something that we do need to be engaged to do for that. Just going down. Have you ever created benchmarks for SDOH groups, homeless populations, for example, if the providers can identify them for you? Yeah, that is a real challenge. As a matter of fact, we have been attempting to even create benchmarks for special needs populations, institutionalized, disabled, dual eligible. Most of our benchmarks currently on the Medicare side are aged non-dual, but we are in the process of developing for some special needs populations. Again, if we have enough underlying data for a special population, we can create benchmarks. The problem is that there's often not enough lives in that more restricted population to enable us to develop credible benchmarks. We can do national average, but getting to a well-managed level, 10th percentile, gets more challenging. We have clients that are using the MedInsight tool for their ACOs. What risk adjusting methodologies are built into that? So that's a great question. So MedInsight is a Milliman data warehouse, been around for 20 years. We have many provider groups data loaded in there, as well as a lot of health plan data. And they use the same benchmarks, the Milliman benchmarks. For risk adjustment, they use, on the commercial side, our MARA, M-A-R-A, Milliman Risk Adjuster. They use that adjuster to do their benchmark risk adjustment. And they also use that on the Medicare side, unless the client prefers the HCC risk adjuster. So that is, again, MedInsight is being used. We also have what's called ACO Insight. That is actually my product that I developed, and many of these drill downs that I talked about today are directly from our ACO Insight tool platform. It's a portal that you can log on to and see your data and drill into various, categories and get the benchmarks and all of that. It's complementary to MedInsight, but it's more provider focused and particularly MSSP focused. So let's see. I think that's all the questions I see out there. So I'll turn it back over to Nick.
Great, and thank you very much. And I want to thank everyone for joining us for today's webinar presentation. We will be sending a feedback notice to all webinar attendees, and we welcome your responses. This is also an opportunity to submit additional questions for our speaker. This now concludes our webinar.